to our webinar series. This is a monthly series on how good practice, policy, and research can improve healthcare for culturally diverse populations. And we're very proud to have the California Endowment as the sponsor of this webinar series. DiversityRx is a nonprofit organization that's been in existence since the late 1990s. We do policy development, research, education, and support to improve healthcare for culturally diverse populations. We offer a number of services and resources, including our DiversityRx website, the Crosstalk listserv, which has over 1,600 participants. We do a conference series on quality healthcare for culturally diverse populations, and we're going to have our 7th conference this fall in Baltimore, Maryland. And then, of course, we have the Your Voice webinar series, as well as communities of practice and peer learning groups. So today, we're very pleased to be co-sponsoring, along with the National Society of Genetic Counselors and the National Council on Interpreting in Healthcare, a webinar called Another Double Helix, Language and Cultural Challenges in Genetic Counseling Encounters. And I'm going to turn you over to our colleagues who are the experts on this subject in just a few minutes. But before I do, I want to just go over with you some of the basic technical kinds of things that you will need to know in order to make this webinar work the best for you. So we will have our presentations, and then at the last part of the webinar, we will have question and answers. And the way it works, with such a large audience, it's best to have the audience muted. But you can submit a question at any time by using the questions window at the bottom of your control panel. So if you'd like, you can indicate if you want your question to go to a particular speaker. Otherwise, our moderator will just ask the question to the panelists, and they will answer. Now, for some more specific details, to send a question or a comment or to suggest a resource to the organizers, enter it in the questions pane. And you can see the blue box over here on the side, and it shows you where the question pane is, and we will try to forward the questions to the presenters and get to as many as possible. So we do expect to have several hundred participants, so we're not going to be able to get to all the questions, but we have a way for dealing with that too, and we'll talk to you about that in just a second. So an important thing to be able to access the question panel is to keep track of the GoToWebinar control panel. And you will either see that as a very large panel on the right-hand side, or you will see it as a very skinny little bar that's right next to it. And what you want to do is get that large view up and select View from the drop-down menu, and then make sure that Auto Hide the Control Panel is not checked. This will keep the control panel up and visible for you during the whole webinar and make it a lot easier for you to ask questions. So what I'd like to do now is introduce you to Renee Chard. She is a member of the Education Committee for the National Society of Genetic Counselors. She received her master's in human medical genetics from McGill University in 1993, and she has been certified by the American Board of Genetic Counseling, and is currently a prenatal genetic counselor at Maine Medical Center in their Division of Maternal Fetal Medicine, and that's in Portland, Maine. So it was her excellent idea to look at these issues of language and cultural challenges in genetic counseling, and I'm going to turn things over to her now so that she can introduce our speakers. Renee?
Thank you. It's really been a pleasure to be involved in this collaboration to bring you another double helix, language and cultural challenges in genetic counseling encounters. Over the next hour or so, we'll be exploring the complexity of genetic counseling encounters and the aspects of communication that are essential to assure optimal, culturally competent patient care. Our speakers this afternoon are Cindy Johnson, Katherine Langan, and Nancy Steinberg Warren. Cindy Johnson received her Master of Science in Human Genetics from North Texas State University in 1984. She's certified by the American Board of Medical Genetics and the American Board of Genetic Counseling. Ms. Johnson has over 25 years of experience in pediatric, prenatal, and cancer genetic counseling. She currently splits her time between the Perinatal Center of Iowa and Mercy Cancer Center in Des Moines. She's a member of the National Society of Genetic Counselors. Katherine Langan is a linguist who has applied her skills in various fields. Dr. Langan has been involved in research at the Summer Institute of Linguistics in Guatemala, where she's studied language development, language vitality, and program effectiveness for bilingual schools. She taught linguistics at Rafael Lindvar University and Mariano Galvez University and several colleges and universities throughout the United States, including Tulane University. where she spent 5 years in the anthropology department. She has been a freelance interpreter working in many states, including Rhode Island, where she worked with the New England Regional Genetics Group to train interpreters. Now a resident of Iowa, she's a full-time medical interpreter at Mercy Medical Center and became the Interpretation Services Departmental Trainer in 2008. She's active in the National Council on Interpreting in Healthcare as a member of the Policy and Research Committee and Advisory Committee for the Standards and Training Committee. And she's a subject matter expert for the National Board for Certification of Medical Interpreters. Cindy and Katherine will provide insight into the perspectives of professionals in the trenches and share tips for effective teamwork. But first, Nancy will provide an overview of the subject matter. Nancy Steinberg Warren is a board-certified genetic counselor and educator who's been in the field of genetic counseling for 30 years. During this time, she's taken on genetic counseling roles in clinical, public health, and education as a genetic counseling graduate training program director. Her interest in enhancing cross-cultural health care has led Ms. Warren to reach out to colleagues and interdisciplinary experts to develop and lead local, regional, and national research and education efforts to enhance recruitment of underrepresented minorities into the field. She's been an avid volunteer and a leader for the profession in this area. As a 2009 Jane Engelberg Memorial Fellow of the National Society of Genetic Counselors, Ms. Warren is developing a website on cultural and linguistic competence, which will be launched later in 2010. And with that, I'm going to turn this over to Nancy.
Great. Thanks, Renee. This webinar is an exciting way to build bridges between the professions of genetic counseling and medical interpreting, and I'm delighted to participate. Thank you. My section will address learning objectives 1 and 4. Cultural and linguistic competence refers to the behaviors, attitudes, and policies of healthcare systems and professionals that enable effective work in cross-cultural situations. Cultural competence means having the capacity to function effectively as an individual and an organization within the context of the cultural beliefs, behaviors, and needs of consumers and their communities. Cultural competency helps reduce health disparities. In this webinar, we focus on providing culturally competent genetic counseling. This involves acquiring cultural knowledge, skills, and having an open, honest, and respectful attitude so cultural differences enhance and don't impede interactions. So how do we get there? Think of another double helix, the weaving and linking of our respective professional roles and seamless communication when working with clients requiring assistance due to their language differences should result in exquisitely coordinated care focused on the client's needs. Whoops, I think I didn't show my screen. I apologize for that.
That's right.
Individuals with limited... Are we good? Okay. Individuals with limited English proficiency, in particular, require our effective communication skills. These are individuals who have difficulty speaking, reading, writing, or understanding English because English is not their native language, or because they came from an environment where English was not the dominant spoken language, or because they have been denied opportunities to learn or work successfully in settings where the dominant language is English. Let's be sure we know the difference between interpretation and translation. Interpreting is the immediate communication of meaning from one language, the source language, into another, called the target language. An interpreter conveys meaning orally. A translator conveys meaning from written text to written text. Interpretation requires different skills than those needed for translation. However, there is some overlap. Interpreters may be asked to translate written messages to spoken messages, called sight translation, or to translate a small amount of written text into written form in another language, such as translating the words on a prescription slip or on an appointment card. Medical interpreters have a vested interest in learning more about genetic counseling, since it is cited as a medical specialty topic for their upcoming national board exam. So let's talk about genetic counseling as a unique healthcare service. Genetic counselors are healthcare professionals with a master's degree from a 2-year accredited training program. After training, we engage in lifelong learning, as expected by our Code of Ethics and certification standards, which fits well with the concept of cultural competence as a process of ongoing learning. Wherever we work, we are members of a healthcare team. We are patient advocates and refer individuals and families to community or state support services. We are educators and resources for other professionals and the general public. Some counselors work primarily in administrative capacities or in research. Unfortunately, there are not many of us. There are currently about 2,500 members of the NSGC. In 2009, 71% of the full members at that time completed the latest professional status survey. The PSS results show that we are a very homogeneous group in terms of gender and race ethnicity. We've collected very little additional information regarding the indices of diversity of our members. Less than 1% of the PSS respondents self-identified as having some type of disability, but we don't know how many counselors are bilingual or how many are familiar with languages other than English. We also don't know how often or how comfortable counselors are in working with an interpreter. These demographics tell us that patients don't have much choice in the gender or ethnicity of their genetic counselor. We see individuals and family members at all stages in the life cycle to discuss concerns, causes, risks, and implications of conditions and diseases known to have a genetic component. We often focus on a specific group of clients in pediatric or prenatal settings or in specialty clinics such as oncology or neurology. Most counselors work in major medical centers in major cities. This can present an access problem for people who are not able to travel or unable to navigate the tertiary healthcare system. Some counselors do, however, work in community-based clinics, outreach settings, and in private practice. My personal perspective is that most people could benefit from having their concerns addressed by a genetic counselor. However, even if just 1% of the U.S. population sought our services, that would present an overwhelming caseload to even the most effective and efficient genetic counselors. Several states employ only a handful of us. It's obvious that people who have the resources and are most able to navigate the healthcare system will be more likely to obtain needed genetic counseling services. The genetic counseling process helps people understand and adapt to the medical, psychosocial, and familial implications of genetic contributions to disease. We gather history information and provide education and psychosocial counseling. That sounds like a plan, but when working with culturally and linguistically diverse clients, let's consider the assumptions we may make. Do we know the client's definition of family? Who in the family knows the family history, or the medical history, or the pregnancy information? One person or many? Who talks to who in the family? Who's not talking to who? Who makes the decisions? Genetic counselors believe that information results in better health care, but do we know what the client wants to know? Is that different than what other family members want to know? What are the client's perspectives on health and illness? How do the client's worldviews, religion, and culture provide sources of meaning and hope? These issues uniquely determine the dynamics of each genetic counseling encounter. There are many steps involved in providing individualized client-centered genetic counseling. We prepare by reviewing the literature and tapping into our experience with the condition or similar situations. Sometimes there's one reason for referral, sometimes several. The client may have no idea why she's been referred, or she may express a reason that is entirely different than the reason on the referral form. The detailed intake information provided may lead to a well-defined pathway of risk and inheritance counseling and testing options, or the evidence provided could lead to completely new territory. Understanding where the client and family are emotionally leads us to use a variety of counseling tools to develop rapport, build trust, gather information, assess and clarify understanding, and identify coping mechanisms. We want to help people use their strengths, and we provide support. We present options and help clients make decisions without telling them what to do. Clients are rarely familiar with a non-directive approach before they present for genetic counseling. Many of our clients are members of vulnerable populations, including pregnant women and children and individuals with disabilities. We see people who may be at risk due to family history or due to maternal age. We see people who are seriously ill. We also see people who do not perceive themselves to be ill and people who are not ill or unhealthy. Counselors and clients may not know what to expect when going into a session. Clients determine the significance of abnormal screening or diagnostic test results in pregnancy, with risk sometimes being a minor factor. Time can be important, since certain tests or treatments are options for only a certain number of days, weeks, or months. We ask about private, intimate matters that a family may typically keep secret, such as babies who died or health problems people had years or even generations ago. We may open up a Pandora's box of psychosocial issues. While we need to maintain confidentiality, the information often carries implications for other family members. The language of genetics and genetic counseling is almost unique in healthcare. Added to that is our usage of complex terminology from other science fields. These concepts can challenge even the most educated English speakers. Unfortunately, few low health literacy and multilingual resources are available. The information shared may be unexpected or bad news. The news itself may cause an emotional crisis, or the family may already be in crisis when they come for counseling. Risk communication poses yet another challenge. Does the counselor have the resources to present risks in different ways, such as with pictures or graphs? No matter how risks are communicated, though, risk perception is another important factor. The burden of risk must be considered from each individual's perspective. Given these variables, we have to step back from each case and assess the effectiveness of the conversation. What evidence do I have of client understanding and satisfaction? Did it feel like a tug of war where the counselor was out of sync with the needs of the client? If so, why? Consider the challenges. Clients and families may or may not want to be there. They may or may not know relevant family information. They may be wary of giving or receiving information. They may be accustomed to being told what to do in healthcare settings. They may face diagnostic uncertainty. Clients may be relieved, confused, angry, sad, ashamed, happy, guilty, scared, or express really any complex of emotions. They may have previous experiences resulting in trust or distrust of the healthcare system and providers. Genetic counselors, on the other hand, want to support our clients. We want to give information non-directively. We may not be familiar with the client's culture, family relationships, roles, and values. Diagnostic uncertainty may drive us to discuss many possibilities and options, increasing the complexity of the session. We may be unaware of the use and value to the client of complementary and alternative medicine to their health. We may not understand why a client doesn't trust us, and we may not adequately build trust. Due to the demands of the systems in which we work, we often have time limitations, and we may be difficult to access. Superimposed on the communication challenges that can occur in any genetic counseling setting for any client, let's introduce the medical interpreter, who's called in to facilitate communications for a client with limited English proficiency. We need to know the interpreter's preferred approaches and about her past experiences. How familiar is the interpreter with the terminology and process of genetic counseling? It may be difficult for the interpreter to prep adequately, and there may be limited time to meet with the counselor in advance. Our sessions can be long, and it's difficult to anticipate what will happen given our individualized approaches. There are many unknowns. Does the involvement of an interpreter in genetic counseling sessions have an impact on outcomes? At least one author found that interpreters who seek to build rapport and trust with the patient rather than remain emotionally detached influences whether the patients accept or decline amniocentesis. The caveat of this study is that none of the interpreters had formal training in medical interpreting. Quotes, rather, they were among the growing core of receptionists, nurses, clerks, and other bilingual personnel in U.S. medical facilities who are called upon to provide interpretation as needed. End of quote. Despite these challenges, many counselors are successfully providing culturally responsive genetic counseling. The concept of cultural humility seems to capture the general essence of how they do it. If we treat the client as the expert and the counselor assumes the student role, this power dynamic lets the client lead the session. As the learner, we ask lots of open-ended questions to seek clarity rather than jumping to conclusions and letting stereotypes lead the way. No matter how experienced we are, we should never forget the basics of empathy. We assess how clients express emotions in words and body language, which may depend on cultural norms or simply on personal preference. As part of the ongoing journey of cultural humility, we continually self-reflect in informal and formal ways by engaging in journaling, case conferences, and peer evaluation. We consider how our attitudes, behaviors, and knowledge change over time and how that impacts our communications with clients. By exploring personal limitations, genetic counselors may realize that interpreters are a great source of knowledge and vice versa. According to the Code of Ethics for Interpreters in Healthcare, the interpreter has the task of always being aware that cultural differences and perspectives and alternative views of the world can lead to critical misunderstandings and miscommunication. I think we need that expertise on our genetic counseling team. In the spirit of cross-disciplinary learning, several educational resources can enrich genetic counselors' knowledge of cultural issues and medical interpreters' knowledge of genetics. These sites provide valuable resources on cultural issues. Reading up on culture broadens our understanding of the spectrum of patient beliefs, worldviews, behaviors, and other factors we may encounter. While we can always learn more, keep in mind that this learning doesn't tell us anything about a specific person or their family. The genetic counselor needs to explore these factors individually with every client. I've listed several resources about genetics and genetic counseling. If you want to find a genetic counselor in your city or state, the best place to go is the NSGC website under the Find a Counselor heading. As the recipient of the JEMF Memorial Fellowship of the NSGC, I'm developing an online resource portal for genetic counselors, students, and other audiences. I include information and resources on health disparities, cross-cultural communication, clinical and teaching tools, and cases. The website will be accessible from the NSGC homepage this fall. I'd love to add your input to this unique resource with the goal of increasing effectiveness of genetic counseling in light of cultural diversity. So please feel free to contact me. Standards of our professions are listed as attachments. These short documents are well worth reading. Thank you for the opportunity to participate in this webinar.
Great. Thank you very much, Nancy. So let's move on to a little closer look on with respect to the dynamics of interpreters working with genetic counselors. And we're going to turn things over now to Cindy and Katherine. And I believe we're going to be starting with a poll. Is that correct?
Yes, we thought it would be helpful to know what are the makeup of our audiences in terms of interpreters, genetic counselors, and other professionals who may be with us.
So you can go straight to your screen and click on the right box, and the web interface will tally things up, and we'll get some answers. So if you all want to start doing that, that would be great. And we'll just take another minute or so. Brittany, I'm going to let you decide when you've seen enough results, and then you can close the poll. I think everybody should be done by now.
We've got about 80% who voted, so I'm going to give it just a couple more seconds, and I'm going to go ahead and close the poll right now. Thank you, everyone, for voting. And now we'll share the results. So it looks like about 41% of you are genetic counselors, 5% of you are genetic nurses, 28% of you are medical interpreters, 22% of you are cultural diversity patient advocates, and 15% of you are administrative personnel. Thanks so much for sharing that information with us. And Cindy, if you want to go ahead and, I'm sorry, Julia, go ahead.
No, that's okay. I was just going to acknowledge the fact that several people pointed out that we didn't quite have all of the potential categories listed on there, so we apologize if we didn't get your profession on that poll. But it gives us a good sense.
Unfortunately, there was no space for, I'm sorry, Julia, I was going to say there was no space for others. We only had 5 options for answers, and so that's why we had to limit it. We apologize.
But let's turn things over now to our presenters and let them take us on the journey for more details about the interpreted encounter.
Okay. This is Cindy Johnson, and I'm going to be kind of starting off for Katherine, and I will be working together throughout our part of the presentation. Nancy has already covered a lot of things that make genetic counseling unique among medical visits that people might be interpreting for. And I wanted to begin by going over a few of those and how they might come up with an interpreter. The first is that, as Nancy mentioned, genetic counselors strive to be non-directive. We want patients to have the information they need to make their own decisions. But in many cultures, medical professionals are expected to tell the patient what to do. And so non-directiveness can be interpreted as indecision on the part of the genetic counselor or sometimes as a lack of authority.
Now, just let me ask you to share your screen. You've got your slides up. That's okay. Just click on the button, and it will be showing to us in just a second. There you go. Perfect.
Is that it? Okay. I'm sorry about that. I didn't get too far. The other thing about that non-directiveness is that we try to encourage discourse between the patient and ourselves, as Nancy explained. We give patients real choices about decisions that we are asking them to make or to think about. And this can come to a person who's used to being told what to do, and also who, even in the United States, in a lot of medical situations, the choices that they're given aren't really real choices. An example might be the person who takes their child for their immunizations and they're asked to sign a form that says, yes, it's okay with me that you give my child these immunizations, but at the same time they're being told that their child will not be allowed to start school unless they have the immunizations. So that choice that's given to the patient is actually more of a formality than a real choice. Nancy also talked about the familial nature of genetic disorders and how that can affect the whole family rather than just the patient. When we look at this, that means that we're taking a lot of extensive family history, and we need to encourage the patient to discuss that. Concepts of disease can vary by culture, and so a hereditary disease may have a lot of shame attached to it. You know, an ancestor did something, and now our family is being cursed with this information, for example. And so we have to be very careful about how we discuss genetic diseases and discuss our view of how diseases happen. Another issue that can come up that's specific to genetic counseling is that most genetic disorders are not curable. We can treat symptoms, we can try to do things that may be preventative, but for the most part, we can't provide a cure. And so the value in diagnosing a genetic disease may be difficult to understand for a patient.
This is Katherine, and I'm going to kind of take us in a little bit of a different direction for a moment. One thing I'd like to say is that on some of our slides, we're going to have very small print. It's not because we don't think it's important to get this information out, but we are we're going to go over the highlights, but because this information will be available after the webinar, please be patient with us. Don't think we're trying to just do things in small print. Some of the issues that we need to be aware of when we're thinking about cross-cultural and cross-linguistic services, one of the first things is the actual first language of the patient or client. And most of us sort of make assumptions that what people auto-identify as the language of service is really their first language, which in many cases may not be the same thing. In Mexico, there are over 250 languages spoken which are as closely related to Spanish as Chinese is to English. So while levels of bilingualism in Mexico are growing among the indigenous populations, it is not safe to make the assumption that because someone comes in with a Hispanic last name, Spanish is going to be their first language. And even if they do speak Spanish, the Spanish may be a highly marked form or maybe a non-standard variety of Spanish. This always is going to confuse the interpreting part of the session in ways that I'm sure you can imagine. One resource that we have at the end of the slides is a document called the Ethnologue, which is a listing of languages spoken by country, by population, and by the relationship of one language to another. And sometimes we know that clinics are not advised of what language somebody speaks when they show up, so it's kind of a guess. But the Ethnologue can be a great resource for people when they're trying to figure out what are the possible languages in order to be able to find an interpreter. Another issue is the level of acculturation of the client to the U.S. and to the U.S. healthcare system. Nancy did, of course, allude to this. And as people spend more time in a place, they become more familiar with it, and so some of the issues may not be as different as we think to start with. Another issue is the personality type of the client or patient and of their social network. People, again, just sort of somewhat oversimplified, but people can either be conservative or they can be innovative. And they can be members of conservative social networks or they can be members of innovative social networks. Innovative social networks have a tendency to be more open, to bring in new people and new ideas more rapidly than dense local conservative networks. So again, just trying to make sure that we're avoiding stereotypes. Another issue is the presence or absence of support systems. A lot of people from different countries, their primary support system is the extended family. They may or may not have the extended family here in the U.S. They may only have a small portion of the extended family here in the U.S., or for the first time maybe in their life, they may find themselves with no family members, and so everywhere that they would naturally go to for support is just not available. And support structures that are in place for people in country, different kinds of support groups for organizations, do not often have enough resources to supply linguistically and culturally appropriate kinds of support. The educational system of the country of origin may be widely different in quality and curriculum and accessibility. So assuming that just because someone made it through 6th grade that they have a basic knowledge of cell structure, and I mean basic knowledge that there is such a thing as a cell, and cells do have chromosomes and chromosomes are made of genes, may not be a safe assumption to make. Even people who've been maybe even through high school or maybe a few years of beyond 9th grade may still not have had that information presented to them. I'm aware of one place in Guatemala where a teacher is still using the handwritten notebooks given to him by his 9th grade teacher who wrote most of that information down in about 1947. So, that's the standard of curricular material available in some places in the world. And, that is just, again, trying to remember what to do with that. Another thing that we have to think about, and both Cindy and Nancy referred to this, are common conceptions about, and I'm putting disease here because that's often what people think of. And this, again, is somewhat overly simplified, but at least starts to give us a paradigm to work with. Diseases are caused by something spiritual, by something environmental, or by something relational. Spiritual, of course, would be things like demon possession or that people have sinned in some way and that causes the disease. Environmental can include bad water, bad air, but can also include the emotional environment that somebody is in. And again, in Latin America, the concept of susto is actually an environmental factor. It doesn't have anything to do with relations or spiritual, but susto, it literally translates being scared. And that is not, it is something which affects people and it affects their health, although it could have an environmental cause. And then there are relational types of diseases like, do people hate me? So it may have nothing to do with what I've done, but if people for some reason hate me, that can also affect my health and can cause me to suffer from some sort of disease. Diseases are curable through different treatments, treatment rituals, and then there are religious rituals that can do this. There are homeopathic types of medicine, so if you drink the right kinds of herbs or you take the right kinds of of exercises, or you do some kinds of things that will take care of it. And then there's also the biomedical rituals. And I think that it's probably safe to call these rituals, because if you have to take pills at specific times of the day in specific quantities, that's the reason why I'm using the word ritual there. There are routines, there are things that have to be done, and they all come together. The one thing about this is that each one of these, both causes and cures, may be interactive in people's minds. So while they may be willing to take somebody's pills, they also may be wanting to do something that comes more out of their culture, different prayer rituals, or take different kinds of herbs or teas in order to continue or to enhance the possibility of a cure. People's views about information is very different as well. For some people, and I think this is probably true for the majority of people in the U.S., knowledge is empowering. It helps us to plan, to prepare, and to participate in treatment decisions. For other people, knowledge is only oppressive. It only adds to the burden as we try to survive and get by day. And for other people, knowledge is actually useless because you can't do anything with it anyway. So why worry? Or another thing, if people think that knowledge is oppressive, because if say for a patient who has a terminal disease, why would you want to tell the patient that? Why not let them have hope and enjoy their life rather than burdening them with the thought that they are going to die? This is not something which is an uncommon kind of characteristic, and I know our Bosnian colleagues deal with this all the time when we get together for family conferences where like a terminal cancer has to be diagnosed, or the diagnosis has to be revealed and dealt with. So interpreting or the different views about information can affect how people will react to a non-directive kind of situation like genetic counseling. For those of you who aren't interpreters, for my colleagues who are interpreters or advocates for culturally diverse populations, just bear with us here for a moment, but interpreting is a complex task. And it is not true that anyone who is bilingual will be a good interpreter. There are many people who are really highly bilingual, but they don't have what it takes to render the message from one language into the next in a coherent and comprehensive form. The interpreting task itself requires high levels of proficiency in both languages for multiple registers, which means that we have to be able to speak as a doctor would speak. We also have to be able to speak as somebody who has less education would speak. We have to run the full range from informal to formal. There has to be high levels of cultural proficiency for multiple systems. There has to be extensive knowledge of the principles of accurate rendering of the message from one source to the target language. And then you have to have highly developed skill in that accurate rendering from the source to the target language. The other thing is that you have to have highly developed skills for managing conversational norms between two languages. A conversational norm would include something like, how do you know when it's your turn to talk? And again, if we step back and think about it, for a lot of people coming into any kind of medical situation, the person who has the right to talk is the medical professional, the provider, because they're the experts and they're the ones who have the right to talk. So if I have a question as a patient, how do I know if they really want me to respond? We often notice that what happens is that people, if they're taking notes, they're not looking at the client or the patient. They're writing down the last thing that was said, and they don't see that little twitch in body language that may indicate that there is something that the patient or client would like to ask at that particular time. Again, if you want the patients, and particularly in something non-directive like genetic counseling, if you want the patients to be interactive, you have to know how to give them the floor, and you have to know how to give them a floor in the way that allows them to think through thoughts that may be difficult to express. I'm sure every genetic counselor has watched people from the U.S. try to figure out how it is they want to ask the question that they're not sure how to ask. And most people need some help drawing those sorts of semi-formed questions out. Those only come out if you have established trust between the genetic counselor and the client. So even knowing how to establish that trust is a way to get it done, or is something that needs to be taken into consideration. And the interpreter is the one who's going to help clue you in that these kinds of dynamics are in play. The other thing that I want to point out is that interpreters not only have to be able to handle different varieties of language. For languages of wider distribution like Spanish, the range of dialects is fairly extensive. Some dialects are harder to understand than others, just in the same way that some varieties of English are harder to understand than others. And you have to remember that the interpreter also has to deal with that wide variety of English. Just think of the number of providers in this country who are not born here and are not native speakers of American English, even if they are a native speaker of what's called a World English. Another thing that we'd like to talk about, just kind of in the way of getting everybody on the same page, are the types of interpreters. And I've kind of classified them for this presentation as three types. They're the ad hoc, they're the professional interpreters of unknown training, ability, and/or qualifications, and there are professional training interpreters with documented training, ability, and qualification. An ad hoc interpreter is often a family member or a friend, but can also be a bilingual staff person. The main advantage to using an ad hoc interpreter is that they are there. So it's convenient. You don't have to think about it. It's just there. A client may bring their cousin or their husband in to interpret for them, not knowing that interpreting services could be provided. It could also be seen as understood that because that's what happened, that's what the patient wants. The disadvantages are that you don't know anything about the proficiency levels for either language in an ad hoc interpreter. You have no way of knowing how accurately the message is being rendered in either direction. You don't know how much information is actually being conveyed to or received from the patient or client. And there could be a lack of objectivity. An ad hoc interpreter, particularly one who is a family member, may interject what they perceive to be the culturally appropriate response, regardless of what the true desires of a patient may be. So those are kind of, we think, serious disadvantages. If you have a professional of unknown training, ability, or qualification, these folks can often be like a volunteer. They can often be self-employed or working for an agency. The advantages are that there's usually convenience in finding someone. Anybody can start an interpreting service without much regulation at this point. They're probably not related to the patient or client. The disadvantages, again, are that you may not know what their proficiency levels are. You may not know what kind of accuracy they have in terms of rendering the message. Again, you may not know how much information is conveyed to or from the patient, and they may not be as objective. Professionals of unknown training could also include people like social workers or case managers or insurance people who work with the client in a different context and accompany them to a medical interview of some form. And we call them professionals simply because they probably are getting paid for their services some way or another. And then finally, you get the professional with documented training, ability, or qualification. Now, again, to be there, just recently, the Certification Board for Medical Interpreters, or the National Board for the Certification of Medical Interpreters, has just rolled out the first test for certifying, coming up with a national certification for medical interpreters. CCHI, which is the, oh, how embarrassing, the Commission for the Certification of Health Interpreters is is designing another test even as we speak. So we are actually, the field of interpreting for medical interpreters is in the process of becoming more and more professional, more and more standardized, and trying to come up with better ways of ensuring safety for the patients and real help for the providers. But we, at this point, are an unregulated field, and we're only regulated by the personal interpreter taking a responsibility for doing the job right. Okay, so that's pretty much of a difference there. With a professional who has documented training, ability, and/or qualification, it means that they have been through a good interpreter training course. They probably have been mentored before they actually were turned loose by themselves. They adhere to the standards of ethics and best practices within the profession. The advantages of having a professional with documented training is that you know the proficiency levels. They have been tested probably more than once for general proficiency and for ability to interpret correctly. You know that they are going to be accurate. You know that the amount of information which is actually conveyed or received to the client or patient. And they probably are not going to be related to the patient, although that could vary if you have a very small population of speakers of a specific language. The disadvantage to having this kind of professional is that they tend to be harder to come up with. The purpose of the interpreter, I know everybody thinks, well, it's, to say the information, and that's true, but we like to think of it as that we facilitate communication between people who speak different languages. And that is a much different kind of way of thinking than just thinking like looking at a bilingual dictionary, and in this bilingual dictionary I can find the word arm in English, and then I will go in my bilingual dictionary and I find the word brazo in Spanish, which, is fine and works as well as it goes. But if you ask somebody to raise, if you ask somebody if their arm hurts, in English this conveys a particular kind of meaning which can include the hand. But in Spanish, you'd want to ask it the other way. Does your hand hurt? Because the hand goes all the way up to the shoulder. So it's not enough to be able to say, I know what the word equivalent is. You have to understand what the meaning of the message is, and not just the meaning of the message, but how the message is nuanced. Is somebody trying to make a joke? Is someone trying to show empathy? Is someone trying to show confusion, frustration, or anger? This is the whole realm of communication, and this is what an interpreter is supposed to do: facilitate the whole of the communication between people who speak different languages. The other role, or the other purpose of the interpreter, is to help establish and maintain good rapport between patients and providers. And this is specific to the fields of healthcare and to other fields like education. But the thing that we have to caveat with this is that we do that rapport only if the primaries, the client, and the provider want good rapport to be established. We do not jump in and make good rapport if somebody doesn't care. That comes from the primaries. That does not come from the interpreter. So how do you know what kind of interpreter you have? Well, in the context, you can probably tell. If the client came in with a family member, you can pretty much guess you have an ad hoc interpreter, because no professional interpreter would just come in with a family member and start interpreting without making it very clear what the family relationship is. Again, if you have a small community of speakers of a certain language, you may have to use a family member. But again, if that family member is a professional, they will make it very clear, I am the patient's sister or brother. And you need to know that before we get started. The clinic policy on interpreters can also help you figure out exactly what you have. The clinic policy is you take the bilingual secretary, and you probably will then figure out that there may or may not have been any training. You can also use clues which are given by the interpreter in terms of how they handle themselves in the situation.
And just in some of those ways are that one thing a professional interpreter will always do is they will speak as the patient in the first person rather than telling you, he said this. You can also gauge that a little bit by just looking at the patient and does the amount of information coming out of the patient's mouth, their body language, their expression match what the interpreter is telling you. So those are just a couple of clues that you can use to see if the person who's doing your interpreting is a professional. Another thing that we know about professional interpreters and genetic counselors is that we both have codes of ethics that we adhere to. And a really great thing is that as Katherine and I were looking at the ethical standards from both organizations, we found that we share a lot of our ethical standards. And the reason that that's important is that it allows both of us to know what behavior we can expect from the other. It allows the genetic counselor to know what behavior to expect from the interpreter. It means that we can have trust and confidence in the entire process, that we are getting the whole story from the patient through the interpreter, and that we can feel confident that the patient or client is getting all of the information that we're trying to give to them. And I think the most important thing about our shared ethical standards is the fact that the goal of both the interpreter and the genetic counselor is for the client to receive the best service possible. So in the end, our goals are all towards the patient getting what they need. It's primarily about what we do to self-debate, right? As we prepare for that one of our tips in a little while is going to be that we meet, if we can at all, with the interpreter beforehand and let them know what information we're going to be talking about, which will allow them to prepare themselves for the type of conversation that we're going to be having. And interpreters themselves will refrain from accepting assignments beyond their professional language capacity, so that if we talk to them about what we're going to be talking about at the session and they say, boy, you know, I don't think I have that level of technical capacity in my training, in my language skills, you might want to find someone else. If we know ahead of time and we can, that will sometimes allow us to find a better interpreter for the job. The second slide is just about how we act as professionals and avoid conflicts of interest. Genetic counselors want to accurately represent their experience, competence, and credentials. Likewise, interpreters are not going to accept an assignment when a family, with a family member or a close personal relationship with someone. Oftentimes, the interpreter will be asked to for advice from the patient. The client will accept the information and then will want to know, well, you know, the genetic counselor is not going to tell me what to do. Maybe the interpreter will. And a professional interpreter, because of those boundaries that they have set, rather than giving advice, we'll turn that around back to the counselor so then she can come up with ways to facilitate decision-making by the patient rather than the patient feeling like they need to be told what to do. This is mainly about the people that we serve. Genetic counselors will serve all of those who seek services regardless of personal or external interests or biases. Interpreters will not interject their own opinions or counsel patients, which gets back to a little bit about what I was talking about in the previous slide, but also leads to the fact that sometimes in genetic counseling sessions, very sensitive information comes up. We may need to talk about issues like abortion, for instance. On the genetic counseling blog, and Nancy or Renee, if you can think of the name of it, because I'm blanking on the name of the blog right now, but there was a situation that a genetic counselor was using an interpreter over the telephone. The patient began asking questions about the issue of abortion, and the telephone interpreter hung up right in the middle of the session, which sent messages to the patient about how they felt about that option, and left the genetic counselor hanging in terms of not having an interpreter, not knowing how this is affecting the patient because she can't communicate with her at that time. And a professional interpreter would not do that. They would continue on regardless of how their opinions affect the information. Another thing that genetic counselors are supposed to do is to refer clients to other qualified professionals when they're unable to support their clients. And I think that particularly is relevant to the interpretation situation, because that is a person, that is a professional that we are referring the patient to get a service that we can't, which is that language interpretation service. And so we really are obligated by our ethics to get a professional interpreter whenever we can. And the last is that we are both expected to treat all patients and each other with respect at all times.
Okay, so kind of to sum up, again, a professional with training and documented training and qualification will always introduce themselves and establish the conversational ground rules. We call this a pre-session. This will be done with both the provider and the client. So nobody is confused about what the actual role of the interpreter is going to be. A really good professional interpreter will always keep the primary participants informed if there is any speech originating from the interpreter. It is not unheard of for an interpreter to misspeak. This is an extraordinarily intensive, brain demanding occupation, and particularly if there are long streams of conversation that go on at a time, just as we do in our first language, we can misspeak. And a good interpreter, a professional interpreter, will stop, will correct that, will let both sides know the correction that's necessary. Will also stop to try to clarify if there is something ambiguous in one of the source messages so that they don't send people down the wrong track by trying to guess what the intent has been. A professional will never, ever, ever, ever answer for a primary participant. The only kind of situation where that could actually happen would be if the patient lapses into unconsciousness, there are no family members, and the interpreter is the only one who has heard what the drug allergies are. We might speak up then, but it's, again, only to preserve the health of the patient. And we will be as unobtrusive as possible, and we will withdraw if we cannot accurately render the information. The other thing that we don't do is we don't stay in the room alone with the client. And this is to avoid the client having gotten some information that they're not sure what to do with, turning to us and saying, what should we do? Or maybe I should have mentioned this to the provider, but don't tell them I said it, okay? So we don't want to keep things from providers, and we don't want to put ourselves in the position where we have to break confidentiality.
So we thought we would finish up by just giving some tips for teamwork. Before the session, again, schedule a professional trained interpreter if at all possible. If not, oftentimes AT&T Language Line, those interpreters should be professionals, and that's often a good option if you have a person with kind of an obscure language that you can't find a local or an in-person interpreter, which is always best. I mentioned before to give the interpreter as much information as possible about what's going to be discussed beforehand if possible. It allows the interpreter to prepare and alerts them to some sensitive issues that they may not want to get involved in possibly. Try to schedule extra time for the appointment. Most of what the interpretation that we use is not simultaneous interpretation, but it's consecutive interpretation, meaning that I speak, the interpreter speaks, the patient speaks, and on like that. So it's going to take twice as long for a session. So if at all possible, you need to schedule extra time for those sessions. Before the session, also, if you can find out what the patient's culture is and share with the interpreter. The interpreter may be able to suggest some types of greetings that you can use at the first to establish good two-way communication between yourself and the patient, or to alert you to some taboo subjects and maybe how to approach them if those are going to be necessary. Also, if you can discuss with the interpreter items that you really need to be clearly understood by the patient, kind of above all else. That way the interpreter can be prepared for that. Once you are starting your session, use those greeting routines suggested by the interpreter if you can. It's important to try to discuss with the patient the non-directive nature of genetic counseling because that's something that not a lot of patients may be familiar with. Explain why the doctor or the healthcare provider has referred the patient, what are your understanding of that anyway, and why the doctor may want you to be discussing that with the patient. And make sure that the patient understands that they are free to interrupt you and even to request not to continue the session if they are getting information that they don't want to have. During the session, it's important not to make assumptions. Nancy touched on this, Katherine touched on this. We all make assumptions about people, but and our typical assumption of someone who needs interpretation is that they have low levels of education and that they're new to America, but they may not be. You know, some people have been here for 20 years and just have never learned the language. I also have met new people to our country who have very low English skills who were, for instance, a medical doctor in their previous country. So you can't make assumptions about level of education or culture just by the language that someone speaks. Always inquire about what level of education they've had, what they remember from their science classes, for instance, so that you can know what level you may need to speak with them at. It's really good to use visual aids whenever you can, and again, appropriate visual aids to the level of knowledge of the patient. And try to phrase questions to ask what you really want to know. Oftentimes, I will ask while I'm taking a family history, how many brothers and sisters do you have? And what I get from that a lot of times is either the ones in the United States or the ones who are living. What I really wanted to know was how many pregnancies did your mother have? How many were live born? How many were male? How many were female? I'm asking a bigger question than what the words are that are coming out of my mouth. Also, it's important to try to avoid idioms. A phrase like, are you going to the bathroom okay? Can mean, are you being able to walk down the hall? Are you urinating frequently? Are you able to have bowel movements? So we need to be precise in our language so that the interpreter can interpret what we want to know. And then at the end of the session, ask the patient to restate, and actually this is during the session too, ask the patient to restate the information in their own words so you can make sure that you are understanding, that they are understanding what you've told them. Clarify any decisions that they're making. Make sure that you understand what they've decided to do. And give the patient a way to contact you and you them. In our office, we often use language line. If the patient, we tell the patients, you call us and then wait. The receptionist knows if she has a person on the phone who speaks Spanish, for instance, that she will get AT&T on the phone and a language line interpreter to help with that. But it's always good to know if there's a family member to call, how we can get a hold of the patient if we need to.
And then we just to bring this, maybe go to your resources section now and do just a few more of the tips, because we want to make sure we have enough time for question and answers. Thanks.
This is Katherine, and we actually had just gotten done with the tips, and we do want to just call attention. The slide I just jumped over was the references that we cited here, and then we have resources that are in print form, and some other resources which are, they didn't seem to make it on there.
We will have your slides available on the website for everybody to download after the presentation. We also will have a resource document. So if there's anything that you think might be missing, we can make sure that that's up on the website. And what I'd like to do, after thanking you for a really detailed and excellent presentation, is turn it back over to Renee and see if she wants to draw out a few more things and ask some of the questions.
Thank you very much. Excuse me. Catherine, a question for you is, from the medical interpreter point of view, what is unique to a genetic counseling encounter as compared to, other medical encounters you may find yourself in?
It's a good question. The number of things are unique. One is that while there are standards of routines that you can expect, you often don't have a whole lot of specific information about perhaps the specific genetic condition that people are looking for. Now, some of that may be because the tests have not been done yet, that the genetic counselor has not yet received that information. But the fact of the matter is that you often, even though it is in one sense, a follow-up type of appointment, it's a referral, we really have very little background information that we can actually study for. And let's be honest, the genetic field changes, every half hour or so. So new conditions are being associated with genetic disorders, new types of patterns of inheritance or transmission of these sorts of disorders are being found. The names are often very difficult. There is often no equivalence for particularly languages of lesser diffusion, which have not been standardized or have not been standardized lately. So there are all kinds of things that come into that. The other issue on this is that these can often become extremely emotional interviews. And if you're not ready for the emotional aspect of it, I think interpreters are often taken off guard. So the technical language, the lack of information beforehand, and the potential for having it turn into a very emotional discussion are things which make it difficult or different from many other types of situations.
Thank you. Another question that we have, and this one, Cindy, maybe you can help us with. If you're in a situation where it is not ideal, in other words, you don't have a professional interpreter and you are utilizing a family member, do you ever find yourself in a situation where you're concerned that the flow of information is being controlled by that interpreter? And if so, do you have any thoughts? And Catherine, you as well may have some thoughts on how to avoid or ameliorate that situation.
I think that the situation that arises most commonly like that for me is when we get a referral for a patient who we are told does not need an interpreter. They come in with a family member. Lots of times it's the husband, and
the husband does all the talking. The wife is quiet. She doesn't say anything, and she's our actual patient. And first of all, I try to discern, is this just a quiet wife, and this is a cultural thing where she lets her husband talk? So I try to elicit, again, getting her to state back to me things that I've said, getting her to answer questions specifically. And if I assess that possibly she's not, and the husband is, acting as really the only client with good English skills in the room, I may ask at that point, would you like me to get an interpreter? And it's a really tricky situation because a lot of times she won't, again, because of the situation with the husband. So I will, in those situations, ask the husband specifically to repeat what I've said, and then again ask the patient to repeat back to me what she's heard. But it can be a very difficult, touchy situation in that sense because it can be insulting for the patient, which is something that you don't want to do as well. So it's usually something that we get through the session and then kind of alert other people to that, the person who's referred them to us, as well as if she's going on in for more testing or for an ultrasound. At that point, because I typically work in prenatal, we may make sure that we have, for instance, an AT&T interpreter on the line during the rest of the appointment so that that can be facilitated.
Yeah, those are really good strategies. Sometimes just asking, you will notice, like, for example, in the case that Cindy used, the husband may not be repeating. He may just be sitting there listening to what's being said, and you could at that point sort of say, would you mind explaining that to your wife and making sure that there's nothing she wants me to repeat or go over again? Because sometimes if these are done in what we call face-saving strategies, which means that you do them in kind of indirect request for indirect directive form, that can be very helpful because then you can kind of see whether you may not be sure what exactly is getting transmitted, but at least you have the opportunity of showing the wife in this instance that it's important for her to hear the information and that you are interested in her response. And the other thing in this kind of situation is that you can fall back on I want to let you off the hook of having to relay all of this information, so do you mind if I get an interpreter on the line right now? That way you can focus on the information that I'm giving to you, and you don't have to divide your attention between being an interpreter and listening to the information.
Thank you for that. Here's another question. Probably for maybe Katherine and Nancy. What are the most common genetic diseases that an interpreter may confront in a genetic counseling encounter, and where might they be able to find more information about those conditions?
Look, this is Katherine, and I guess, some of the things that are the most common kinds of things, well, it's going to depend on your population, isn't it? Because certain genetic disorders run through different kinds of populations. I know that in my practice, Down syndrome, trisomy 13 and 18, those are the ones that most frequently come back, and again, mostly in response to an irregular AFP result or some other kind of blood test. But again, it's, and for somebody who's done enough genetic counseling, it's very easy to think, well, this is what it's probably going to be about, and then you walk in and it's something you've never heard of. And that's where it becomes more difficult, is if it's a condition that you've never heard of. And the reason why interpreters want to know about that is that the deeper our understanding of a particular condition is, the easier it is for us to render clearly the symptoms, the possibilities, the reasons why it may occur into the other language. Medline Plus is a great place for information on genetic counseling in a variety of languages. Also, genetest.org is a great reference. And the other one is medlineplus.gov, and I think we have that up on our site.
Those are great suggestions. I guess I also would suggest that what we need an interpreter for may be based on the settings in which we're working. So if we're in a prenatal setting, we may be seeing individuals who have abnormal ultrasounds or abnormal chromosome results in pregnancy, or in a cancer setting where there is informed consent required for breast cancer testing. But many genetic conditions are very rare, so we don't necessarily have a whole routine of what may be encountered in that setting. But certainly we're probably wanting to call in interpreters whenever there are significant issues, lethality, fetal losses, and genetic testing requiring informed consent. And in terms of resources, in addition to what Katherine suggested, I think we also have some other resources posted on the website.
And sometimes, this is Katherine again, sometimes we end up doing genetic counseling without a genetic counselor. This will happen, yeah, thank you. So it's particularly like for pediatric subspecialties where some of these rarer kinds of conditions manifest. Those are the places where we usually walk in and somebody hits us up the side of the head with something we've never even heard of before.
Thank you for those points. Here's another question from the audience. How do you handle communication issues, and I think this could be from the genetic counseling or the interpretation point of view, that arise when there is an elder who is in the position, culturally speaking, of being the decision maker as opposed to the patient? Have you come into that situation before? I have really not. This is Cindy speaking. I have really not been in that situation other than in the husband-wife situation that I spoke about earlier. And in that situation, I typically try to elicit as much of the wife's feelings as I can. And oftentimes in the end, what her desire is to do what her husband wants her to do. So oftentimes that does get resolved that way. That I have not been in a situation where there was an elder that needed to be consulted. Nancy?
I think your response would be how it should be handled, or sounds good to me. I think we're trying to elicit the patient's viewpoint, and if they are deferring to someone in their family or in their community, perhaps they could tell us more about that relationship, and we can learn from that and then support that position.
This is Katherine, and I agree with my colleagues 100%, because again, we can't assume that the individualistic paradigm of the U.S. is the only paradigm that actually works well. But I think one other thing, though, is that sometimes we may have to try to figure out if there is something that maybe something that borders on abuse or borders on an undesirable kind of situation. So in that sense, it may be that the interpreter, again, reads body language or reads something else. But if you only rely on an ad hoc interpreter, you may not realize that the person most involved is having some resistance to the decisions being made. And again, a really good interpreter will be watching the body language of everyone in the group, and we will try in the most professional manner to leave the door open, and we may suggest it might be a good time to do a one-on-one interview with the person most directly involved.
So Renee, I'm going to suggest that maybe we might have time for one more question, and then we can wrap it up.
Okay. So and this maybe Nancy can take this, but anybody can. When enrolling patients in genetic research, what ethical, moral issues need to be considered, and how do you deal with the confidentiality of patient genetic information?
Wow, I'm not sure I have a response for that question in particular.
Or Cindy, I don't know if you want to tackle that. Well, I think that those issues are not specific to research. Certainly we talk about the confidentiality of genetic information, particularly in cancer genetic testing when we're offering that, and with other genetic tests that are offered. So I think that it's very similar, but these are difficult issues to address and complex issues to address, even when you're speaking with someone whose first language is English. And I think allowing that extra time and just making sure that the concepts are getting across accurately is important.
And this is Catherine, and I'm just going to jump in a little bit too, because I've watched Cindy do this, and one of the things that she always does very well is she says, I'm going to talk to you about research that's going on, but you can stop me anytime. We're going to ask you if you want to participate, but if you don't want to, it makes absolutely no difference to the way that we are going to take care of you here. This is a completely free choice for you. She's very good about getting that message out, both at the beginning and somewhere in the middle and at the end when people are have asked questions like, what are you really going to do with this information? So I think that, just repeating the fact that it is not related to ongoing care and the quality of the ongoing care is a very important piece of that.
Great. Thank you, Catherine and Cindy, for those responses. And thank you also to Nancy and to Renee. You guys have given us a great deal of information about how to manage language and cultural issues in genetic counseling encounters. And what I want to let the audience know is that the questions that you've sent in to us, we are hanging on to. We will be sending them to the speakers who will try to answer as many additional questions as they can, and then we'll let you know when that Q&A is available. As well, the resource materials are online, and we expect to have a recording, video, audio recording of this webinar online next week by the 23rd. You'll also be receiving an email from the GoToWebinar program that will have a link for you for a satisfaction survey, just so you know that because we did this as a joint production, those people who are part of the Society of Genetic Counselors will have a link for a survey specifically designed for them, and anyone else who has been on the webinar who isn't part of that society can answer our regular satisfaction survey, and that will help us make improvements for future webinars. Our next webinar we anticipate having in the fall, so we're going to give you all a nice summer break, and you can, by having registered for this webinar, you'll get an announcement from us before that happens, but you can also check our website, which the website address is right there below for you. And we very much appreciate both our speakers and our audience, and we hope to see you on a future webinar. Thanks very much.